saw the commercial for this document. Did you see the commercial? One person, I didn't see it. But all these people were calling my mother-in-law and saying, I saw your son-in-law in this commercial. And is he allowed to talk about incontinence? For about a certain time. I see a lot of this. It's a big part of my practice. I'm pretty passionate about it. It's fun because I get to work with a good team. In medicine, a lot of things are doctor-patient, but this is one of the things where it's a group of people. When I was thinking about this, I decided to have the whole team here and talk with them as well. So tonight we have Erin Lamb. She's the clinical director of physical therapy here at Holland Hospital, and she specializes in pelvic floor dysfunction. And we have Julie and Lisa there, nurses from our office, and they are the incontinence team, and they do most of our work and most of our heavy lifting. So, thinking about this talk, this is what I did not want to do tonight. This is supposed to be me. This is you guys over here. So this guy's sleeping. This is, I don't know what they're talking about, the snow, and a little flirting going on here. We don't want that. Okay, this is what we want. This is really informal. Ask any questions you want to ask. The way I've set this up is we're not going to, I give a lot of these talks and we just talk about things and talk for an hour. We're not going to do it that way. What I've done is selected 3 patients that I've seen in my practice in the last 4 to 6 months represent probably 95% of pathology you see and problems you see in voiding dysfunction. So it's going to be a little bit more interactive than most lectures. So this is the first case. And if you got a question, throw up your hand, stop, and we'll talk about them. 70-year-old G3, P3, that means she's been pregnant 3 times. She's had 3 vaginal deliveries, female, postmenopausal. She came to me with 7 years of worsening, bothersome frequency, which means she felt like she had to void a lot every 45 minutes. Urgency meaning she feels like she has to go quite urgent. If she was in this room right now and it came on, she'd have to get out of here and get to the bathroom. With leakage associated with this, wearing a couple pads a day, urinating at night, after 3 times. Asked her, she said she feels like she has to get up and go small volume of urine. Burning when she urinates, that's dysuria. Pain within her pores. Half dozen UTIs a year, urinary tract infections. She denies stress incontinence. We'll talk about this later, but stress incontinence is leakage with black cough and sneeze. She doesn't have that. She just feels like she has to go when she leaves. So, talking with her a little bit more, she likes coffee. I used to practice in Seattle, so I like coffee too, but she drinks 4 big mugs a day. Adds on a couple Diet Cokes. Okay. She doesn't think she's constipated, but when I talk to her, she's pretty constipated constantly. And she's a pretty healthy lady other than that. No medical problems, no diabetes, no surgery. So, what do we do for this? Mainly we talk to the patient about her issues. We have a few screening questionnaires. We do a physical exam. We look at her urine. We do a PDR, which means we have an ultrasonic way, non-invasive way to measure how efficiently she's emptying. Sometimes with these kind of procedures, we'll choose to look in the bladder with a little scope to make sure these aren't from a stone or a polyp. Sometimes with infections, if you came to me for kidney infections, I'd want to do a renal ultrasound to make sure it wasn't from blockage or a stone. So for this lady, she didn't really have any risk factors or signs of anything going on in the bladder, but she had some urinary tract infections. So I think we ended up doing a renal ultrasound. So what are our findings? We did all this, and we said, well, in the office, she had UTI when she was seeing me. She emptied well. I got a renal ultrasound. That was normal. On a vaginal exam, she had atrophic vaginitis. So I told her she's 70, she's postmenopausal. After menopause, your ovaries don't make estrogen and progesterone efficiently. And so what happens is, a lot of things happen, but at least in the area of the pelvis and the vagina, your tissues thin out because you don't have that hormone there. The pH of the vagina changes, which means you're more susceptible to infections, and you can have some burning and dryness as well. We also assess their pelvic floor strength. That's the ability to, we'll talk about this more in a little bit, the ability to clamp her pelvic floor down and have some control. She had real poor awareness of her pelvic floor and core strength overall. So, diagnosis, I say, okay, what does she have? And I like to make silos for diagnosis, so a bunch of different problems and tackle them one by one. So, she had chronic urinary tract infections, she had atrophic vaginitis, constipation, she has high dietary irritant intake, so the coffee and caffeine. She just pelvic floor weakness. So, what are we going to do about that? So these are the options. We're going to break these down one by one. For the UTIs, we can do vaginal hormone replacement. We can do probiotics. We can sometimes, in severe cases, do suppressive antibiotic treatment. I'll tell you what we do in this lady. We do not do that in her. We can treat constipation with the bowel program. We can change what you're eating and drinking, or at least how you think about it. And we can send you to physical therapy. So, if this was the real world in my office, I would be thinking all these things. But then what I would do, I would come over to one of these ladies and say, okay, there's this lady in here. This is what we can talk with her about. And they would come in and start working through those things. So what we're going to do tonight, instead of me droning on, we're going to hear it like you hear it from them in the office.
He mentioned the coffee. So there's different things that you eat and drink that can cause irritation to your bladder. Coffee is a big one with the caffeine. Diet Coke, the carbonation, the artificial sweeteners, and the caffeine in that as well. Those are all things that irritate your bladder, make you go more often, give you urgency, frequency, and even can help contribute to the bladder infection. Drinking enough fluids as well. A lot of people think the coffee is drinking enough water. You need to drink enough water to kind of help your urine stay less acidic, which in turn can help flush things through so you don't keep the bacteria in there that'll cause the infections as well.
I get constipation. That's my specialty. I'm the bowel girl. So constipation. Every once in a while, everybody has a little constipation, right? Well, on the average, do you have a soft bowel movement every day? That's the things we ask you. We don't want you having hard little balls. That is not a good bowel movement. Because then you're sitting on the toilet and doing this. No, that's not good. We don't want that. We want you to have a soft bowel movement. No offense, soft tubes, not little round balls, okay? Why do we worry about constipation? Because ladies, what happens is when we have our bowel movements and we don't evacuate everything, tiny microparticles of stool are sitting back there on your hind end, okay? I don't care how clean you are. When that sits there, it can sit there in your underwear. Guess what? Then you have a pad on, okay? And it's warm and it's moist. And no offense, I call it the hot box. Because what happens is moist, hot is going to cause bacteria. And next thing you know, you're going to get a urinary tract infection. So your bowel and your bladder go hand in hand. So how do I have a normal bowel movement every day? We don't want you to take X-Lax or anything like that. We want you to have more fiber in your diet. Us Americans, we don't eat enough fiber. Fiber supplement, powder, put it with a glass of water, Metamucil. Eat more fiber, more water, fruit. Those are the things that help get your bowels going and that you can start having a bowel movement. I say raisins and peanuts and things like that, those are good for you. So constipation is a biggie. And everybody goes, well, I've always been constipated. Well, guess what? You have not always been 62, 63, 64. Now you're having problems. You're not as active as you used to be. Those are some of the things. You don't drink enough water because if I drink more water, I'm going to leak. Well, guess what? You're going to leak anyway. I don't care if you drink 2 cups of coffee, 2 cups of water, or whatever. If you have problems with leaking, you're going to leak anyway. I have had people who come in, I only drink 1 glass of water a day, and I still leak. I said, well, you might start drinking because you're going to leak anyway. You've got to make sure you keep your bowels going, okay? So that's my constipation speech.
Okay, then next. So if Julie and Lisa don't attack you with their diet and bowel and all of that good stuff, then we will. We take a lot of those components. For whatever you haven't heard, then we'll dose you up with more information. And really our goal is to give you guys a toolbox to work from. We can't fix you. We can set up a stage to do that, but you have to be the active participant to make that change. And so we can give you all the suggestions, and then unfortunately there's some work on your part here. But I wanted to educate you a little bit about the mechanical component to all of this too. Part of the problem with the constipation is that not only could you not be putting in the right things in your body to produce a good bowel movement, you might not be pooping the right way. You need muscles in order to poop. And so over here, I gave you guys a nice little side picture of the pelvic floor. This thing has such a big role in your body. It is not just something that holds in urine and stool. It's the core muscle for your body. So it's what makes you stand up, it's what makes you sit down, it's what makes you walk. So if you've got an abdomen full of stool sitting on top of your poor bladder, and then you have this weak band of muscle underneath there, you don't stand a chance. The minute you jump, all of that heavy stool is punching your bladder, and you're going to leak because the muscle below can't withstand it. So you're setting yourself up for failure if you're not having good productive movements. And like Julie said, if you go to the bathroom every day, but it's little grapes, you're not keeping up with what you're taking in. You're backing up, and it's going to get heavier and heavier, and then you're going to be leaking because of that as well. The other component here, over here, I've got the picture of the abdominal wall and all the different layers. And unfortunately, as women, after we've had kids, and as we age as well, the abdomen starts to protrude forward if you're not strong. If you don't stay up with your strength on that, we tend to get weak and we stretch because we're more flexible. And so we tend to be weaker and more flexible, and men tend to be tighter and stronger. They have the harder bellies and are tending more towards hernia and that kind of thing. You have to have a good abdominal structure in order to generate a good bowel movement. And so you need to be able to pull in so that you can generate some strength here and be able to relax the pelvic floor in order to go. When you don't want to go to the bathroom, you need all of those things to tighten up and hold you while you're walking around. So one thing to be able to find them when you're laying down, you have to be able to find them when you're standing. And unfortunately, you have to be able to find it when you're not thinking about it. That's the other trick. So those are some of the standpoints that we'd be coming from as well. And I want to also just encourage the fiber piece of it too. We give you diets back, and Americans have terrible, terrible diets. You need to eat fruits and vegetables. There's some really neat handouts that we have that can illuminate what exactly has fiber and how much you should be eating, and it's about 25 to 35 grams a day that you should be eating of that good stuff.
Us ladies, when we lose our ovaries, okay, either you had hysterectomy or you had go through menopause, they dry up and they go away, basically. And so what happens is we lose estrogen. What happens when we lose estrogen? We sag here, we get big bellies here, because I'm the poster child for that. And what happens is we dry up down below. Our tissues get dry, they get frail, they get thin. You'll have difficulty having intercourse, it gets dry and it hurts. You notice more urinary tract infections because the skin is not healthy. It's just too dry down there. And you'll end up having more problems with urgency and frequency because the tissues down there around your urethra where you urinate out of get like plumpy. It gets different tissue. So we need to replace the estrogen. Now, we're not telling you take a tablet, okay, because we know there's the whole cancer scare, everybody gets scared of estrogen. What we recommend is a fingertip amount of estrogen, very low dose. It goes right in the vagina before you go to bed, after you urinate, before you go to bed, a little fingertip of estrogen right around the urethra and then the vagina. We recommend up to 2 weeks every night. Right? You can go up to 6 weeks if you're really bad. And then we recommend Monday, Wednesday, and Friday, or 3 times a week, okay? Now, what if you're sexually active? Okay, Herbert will not start talking like a girl if he gets a little estrogen on him. No problem. Don't worry about that, okay? The one thing is we want fingertip amount in the vagina or around the urethra first, and then in the vagina. That helps keep infections at bay. It helps with their urgency and sometimes the frequency, and keeps your skin down there nice and plump like it used to be when you're like 30, right? So that's the estrogen thing. Now Lisa's going to talk about probiotics for just a second.
Probiotics are something that you can take. If you take antibiotics quite often, it kills off your good bacteria and your bad bacteria. Probiotics is something that you hear a lot about, that you often will take pills or yogurt, those kind of things, which do help in the gut and those kind of things. But you also have a good bacteria down in your vaginal area that also helps fight the bad bacteria. And so we also recommend Floragen. It's a pill, but you actually put it in your vagina. And you do that at bedtime as well, and that absorbs in there, and it kind of helps replenish the good bacteria that you lose from all the antibiotics that you take to treat your infections. So that is a thing that's over the counter, it's not prescription, so if you take antibiotics quite often for different things, that is a good way to go as well. We gave you a folder when you came in here, and they're on your chairs, but there's a lot of this information is in there. So the constipation, the bladder irritants, a lot of that kind of stuff are all in there, as well as some other treatments and things that we may or may not discuss tonight. But that's a folder we give to a lot of patients we see in the office, and we cover that. The vaginal health is in there too, so that kind of explains what Julie just was talking about, and a lot of the information there too. So.
I think I got most everything. I got ahead of myself and just went off of memory, but you talked about the mechanical problems there with the bowel movements, and then further building off of whatever they've started with you guys. Biofeedback is a tool that they use and we use as well. Sometimes with these patients, they're not getting the urine out because the muscle can actually be weak enough that you're not holding it in, you're not storing it, so the bladder's not filling really well, so then you'd obviously want to strengthen the muscle, but the muscle sometimes is too tight. If there's not a lot of muscle support in the surrounding muscles, like your hips, your butt, your abdominals, the pelvic floor sometimes gets overloaded and has to do it all by itself, so it gets really tight and really short, and then you're not emptying your bladder all of the way. It's like trying to pee on a closed door. You know, so that also can contribute to urinary tract infections as well because you're never getting all of the urine out. Now they said that you were emptying well, but sometimes it seems like you're getting a good empty, but the flow will just be kind of slow and choppy, and it's not the nice flow from when you were younger where you go to the bathroom and you empty and you're like, that's wonderful. And so we really look on biofeedback to see, are you too high, are you too low? Do you know how to go high and then go low? Can you bulge? All those good things. And it's really great to give your brain that visual. The brain learns really nicely when it has something to actually see, because you can't really see your pelvic floor all that well. And contracting that muscle, most people didn't even know they had a pelvic floor. I just saw on Facebook yesterday, somebody linked me in on a Facebook post of like, I didn't know I had a pelvic floor. So, but you do, yeah.
All right, so it's as easy as that. So what happened with this patient? Again, chronic UTIs, we did some vaginal hormone replacement, we did probiotics, we did not do suppressive antibiotics. We started on a constipation program, they changed their diet with food as well. And they did some physical therapy. And what happened? Frequency, every 45 minutes, now it's 2 hours. Urgency with leakage, we're down to less than a pad a day. Not getting up at night. The burning and pain with intercourse resolved with the hormones. And all that together reduces the UTIs to less than 1 or 2 a year. So, happy patient. And what questions do you guys have? Good night. That's correct. So, the question was concerning the list that we have of bladder irritants, that cranberry juice is on there. And I think the implied question is, well, I've always been told that cranberries are going to help me from getting UTIs. If you look at the data, that's false. What cranberry juice probably helps with is if people are drinking it, it's fluid, right? There's a lot of water in it. If you look at the actual data on cranberries, it's not going to help you. The way it's problematic is cranberries are acidic. And as Lisa was mentioning, acidic foods, tomatoes, other things that are on there can cause irritation. Now, not everybody's going to have that, but some people are particularly sensitive to that. Yeah. So, well, I don't think it's harming you. I think the fluid in it is great, as we discussed. I don't think the actual cranberry is helping you. The data, I don't have any data to show you, but when it's been looked at scientifically, it's not been shown to make a difference in the fluid. So that is probably better. Yeah, so the question before I answer was concerning the other irritants, some fruits and vegetables that we would consider fairly healthy and tasty.
It's not necessarily an eliminate everything kind of scenario. I rarely find that people have to take everything off of the irritant list. It's really what affects you. If it's somebody who's got a really painful bladder syndrome, then you kind of got to eliminate and then slowly add back in. But if you've always eaten peaches and you don't find that you're running off to the bathroom having to go horribly bad, you're probably good with peaches. But a lot of food is quite acidic, and our diet as Americans is very acidic. And so you're producing acid waste.
It comes with an applicator. The first thing we say is get rid of the applicator. The drug company wants us to use more cream so you can buy more cream. No, we don't want that. We want you to use a very little bit, fingertip amount on the end of your finger. You do it before you go to bed. After you urinate, you're laying down or on the toilet, you do it after. Put it on and then go to bed in the evening. Yeah, oh, it is prescription.
And that one is a prescription, and we evaluate you if that's a safe thing. If you've had hormone positive, receptor positive breast cancer, if you've had uterine cancer, if you've had reactions to estrogen-containing products, you might not be able to have those. But for most women, they're able to have those independent of those processes. So in terms of the diet and fluid, I think you can try to, and we're not saying you can't have any of those things, but try to have a healthy diet, healthy fluid in terms of irritants. Try to have a fiber-rich diet and not be constipated. In terms of, Erin can answer the back half of that.
I'm going to show you guys a couple little things to check on. I think it's on the next slide here, but I want you guys walking out of here with some tools to use to understand how your body works as well. So we'll get to that a little bit. But simple walking programs, if you don't use your muscles, you're going to lose them. And unfortunately, our lifestyles are very sitting-based now. And so you have to, the more active you remain, the more mobile, and I'm not talking about being a gym rat. You don't have to have an amazing exercise program over at MVP, but just be active and use your muscles. The more that you stimulate your muscles, the healthier they're going to be. And knowing what they do is half the battle. Knowing that you have these muscles and why will help to prevent problems in the future a lot. And those are some of the tools that we want to give you tonight.
All right, so let's go to the next case. So same result, but different flavor. So 55-year-old woman who's been pregnant twice, 2 vaginal deliveries. She comes in and is complaining of several year history of leakage of urine with anything active, laugh, toss, sneeze, jump on a trampoline, run, walk. 3 pads a day, it's getting worse over time, it's bothering her. She has minimal urgency, no urgency, frequency she can hold. It's only with activity. Again, she's very healthy otherwise, no major medical problems. So what do? We talk to the patient, we examine them, we fill out questionnaires. We can do a cough test, which basically means, while doing a pelvic exam, we have them replicate some of the activity. So the coughing, the laughing, bearing down. And we look and we see if it's as easy as seeing if they leak. We also see if there's a characteristic tipping that the urethra does with this as well that can help us figure out what's going on. Occasionally we'll want to look in the bladder. Occasionally, if it's a little bit more complicated with other kind of bladder issues going on, we can do a test called urodynamics, which is a way for us to figure out how big the bladder is, how stretchy it is, which is called compliance, what the pressures are involved in terms of voiding and storage. So for this kind of case, I wouldn't obtain these, but sometimes we do that as part of the evaluation. So what is the diagnosis? This is called stress incontinence, and that's kind of a fancy definition, but it's basically what Erin talked about before. When you're doing something active, and the pressure you're generating in your abdomen is greater than the pressure that's holding that urine in your urethra, you're going to leak. It's like 2 people pushing on a door, the stronger one's going to win. And if there's more, if your urethra can't hold that shut, you're going to leak urine. That's all it is. And so how common is this? It's very common. I think these numbers are low. I think women and men that can have this are sometimes embarrassed by this. So these numbers are probably underreported. But we reported numbers, 25% of premenopausal women, 40% post. Not all leakage is bothersome. We're going to talk about the next case. I see plenty of patients who have a little bit of this, and they tell me, hey, it doesn't bother me, and that's okay. We don't do anything about it. But when you do have it with bother, it can reduce the quality of your life considerably. People become less active. It can cause some problems with sexual confidence. Fewer than half of the women who consider this to be a problem in their life present as you're going to see, we can help you with this. So when do we see this? We see it at all ages, tends to peak in the late 40s, but I certainly see it much later than that. Risk factors for this: white race, obesity, pregnancy, vaginal childbirth. And this is the thing, I have many patients that have this after they've kind of gotten to know me a little bit and they're confident with their office. They'll say, you know what, I have this weird thing that happens. I'm sure I'm the only one in the world. They leak with intercourse. And I say, yeah, everybody, that I've ever taken care of has that. So it's a very common thing. And it keeps people from presenting because they're embarrassed about it. So what are our treatment options? We can observe it. If you're not bothered by it, that's okay. We leave it alone. We can do stuff as simple as pads, as behavioral modifications. So we have you do time voiding, which means we have you urinate every 2 or 3 hours, whether you feel like you have to urinate or not. The thought is if your bladder tends to be more empty because you're emptying more, when you have that pressure, you're just not going to leak because there's more of a tendency to have an empty bladder. If you're motivated to have therapy, physical therapy is a big component in this, and then there's some surgeries we're going to talk about as well. So, here.
The pelvic floor picture I put up here is to show you the intensity of how big this muscle is. So really it goes from sit bone to sit bone, all the way across. And it goes from tailbone to pubic bone, from front to back. So it truly covers every single part of the floor. And it would mimic really what the abdominals do. So now you have your pelvic floor, and men have the same ones. You guys aren't off the hook with this either. It's just got different parts. The pelvic floor has a couple of components to it. It has quick contraction muscles. So it would be like your cough, sneeze, sudden jerking, sudden lifting kind of movement. The more outer layer up in here is going to be that reflexive, quick hold. And it fatigues fast. It only is there for a little bit. So it's kind of like your biceps. They can't hold something out for a long period of time. It just is there rapidly and then gone. The deeper layer in here, these are more of your postural muscles. So these guys have to last for the whole day. People often find that their symptoms get worse as the day goes on. And that's because these guys are getting tired. They're holding you up and they're standing and walking with you and lifting with you and holding kids and grandkids. And then as you get fatigued in the day, it starts to fail and you start to leak more. So a lot of times people are saying that by dinner time they're toast and they're a lot wetter. So that's where that's coming from. The abdominal girdle is just as important. Now you have to be able to find this muscle. You have to be able to find this muscle. You have to have butt muscles. But you have to be able to isolate them first and then bring them all together as a team. So your abdominal muscle, I would say probably 90% of the people, what did you say, Kathleen? Do it wrong? My partner's back there. They don't know how to find their abdominal muscle either. And if you can't find this, you're going to leak as well because it's not holding up the bladder. There's a picture in here, I think I've got it. I'll show it to you in a second. Showing you how the bladder actually connects to the abdominal wall. So that as this falls and weakens, your bladder falls too. So one of the things that I like to work people toward is a hut. So now pardon me that I'm gonna quickly hut. If you sound like a football player and you say hut, hut, you'll actually, it's kind of cute, huh? You should feel all of your muscles go. Your pelvic floor, your abdominal muscle, everything should go in and set up. So the force in your trunk has to move up this way, and that's what counterbalances gravity. Okay? So hut, try it. Hut. Do you feel that? Now we're ready. See, it's fun. People always walk by our room and they're like, what are they doing in there? But it will help you to find those muscles properly. And many times, now cough a second and feel your abdomen if you cough. Don't cough on your neighbor. I saw you. If you cough and your abdomen goes out, we have a problem. If you're coughing like, guess what you're doing? You're just going boom, 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 boom on top of the bladder. When you cough, if you grab a grandchild or a child and you feel them cough, they do it right. They haven't been spoiled by all these problems that we have yet. When they cough, everything goes hut, 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 hut. When you cough, everything should pull in and up. And so we teach you all of those components that you're actually using your muscles the right way, taking pressure off that poor bladder, and then you need to learn how to jump. You need to know how how to move and lift using all those muscles. You don't want to do Kegels your whole life. You want to have them work the right way. If we just gave you a Kegel contraction program for the next 50 years, you'd be doing a disservice to you. You have to learn how to use those muscles. So I talked about isolating and integrating. Can you find them? Do you need help with biofeedback? Do you need help with electrical stimulation to wake them up? Now what do you do with them? How do you use them? How do you go to the bathroom? How do you do your lifting? And then we also, for this patient in particular too, with stress incontinence, we are actually finding also that a lot of our stress incontinence patients also have back pain or hip pain because it's a breakdown of the pelvic girdle. The pelvis is kind of cool. Kathleen, you want to grab the model? The hip, the pelvic bones don't just connect like other joints. They basically are like a puzzle piece. Thank you. They're a puzzle piece together, and muscle holds them together. And if you don't have the muscle holding it together, these bones don't come together all the way, and they're loosey-goosey. And it'll actually make you feel loosey-goosey when you're moving around. And so if you don't have these muscles cinching together, we call it force coupling. You cinch it together like with your hip. You get pain. You get pain in the back. Little points here, and here, and here. Familiar? Because those joints get a lot of the strain, and we find that as those start to loosen and the pelvic bones start to kind of come apart, and we call it kind of sloppy pelvis syndrome, you leak because the bladder then is like, okay, and you can't fire your muscles really well. So that's kind of an angle that we'd be coming from. And I'll look at this next slide here too. This was I get kind of excited here. But the pubic bone's right here. Here's the bladder, and look at this. And it actually connects up above, but the ligaments and the kind of the saran wrap around the bladder come up and they insert on the abdominal wall. Okay, so that's actually helping to hold up your bladder. And then you got all these muscles down here helping to build the vaginal canal, the rectal canal, and the urethra. And as this starts to fall and go, you can see the bladder then is not being anchored and pulled up by anything. And I like to give an analogy of a boat with the ligaments and the dock. Your dock is your bones, your bladder is the boat, and you've got ligaments that hold it together to the dock. Those are your ties. And if the ligaments start to relax because you're misusing your body, or you're not strong enough, your boat starts to sink because your water level is low, your pelvic floor is low. So if you build up the water level, maybe you need some new ties. Maybe you have to get that boat back up with some surgical procedures to do that. But you're going to have to stabilize and hold the bladder in place and learn how to use your body the right way.
I didn't tell you, but this patient in real life didn't need physical therapy. She had good coordination, and you can have these problems with good coordination. So that's where I come in, the surgeon, and talk to you about, well, there's some other things we can do. There are two procedures. This is one of them we do. I probably only do one or two of these a year, but I just include it for sake of completeness. This slide, if you cut me in half with a saw like this, and then look to the side, that's what we're looking at. So this is the bladder, and this is the urethra right here. And so we have a procedure. This procedure is called urethral bulking. The way I think of the urethra, it's kind of like a donut. Okay? And so sometimes, independent of the pelvic floor, your donut hole can just be too big. Okay? So what this procedure does is it makes the donut hole smaller. And we can do this in the office where we insert a scope and inject the material into either side, and it makes the donut hole smaller. Okay? Now, the reason I only do a couple of these a year is the other thing we're going to talk about in a second is the superior procedure. This is good in a lot of ways. It doesn't require an anesthetic. Okay, so I can do this in my office. It's well tolerated. I can do this probably in about 3 to 4 minutes. And so patients that are a little bit older, that have a few more medical problems, that we're not getting them where they need to be with other modalities, that want something done surgically, this is a great option because it's safe. They don't have to go upstairs to the OR with the anesthesia and all the things that can go along with that. The issues with it just doesn't work quite as well as the next thing I'm going to tell you about. If you came in and said, hey, that first thing sounded good, what are my odds of doing well? I'd say it's probably 40 to 50%. And even women that do well with this, you have to have it repeated every once in a while, so maybe once a year, you have to, your body reabsorbs some of this material, so you have to have a little bit more clearance. So I think it's an okay option that we can offer people, but it's not the gold standard. This is the gold standard, okay? This is the urethral sling, and I think it should be called the urethral hammock, and I'll explain why. But this is PTFE, which is Gore-Tex, okay? And they come in all different materials. 20 years ago, before I was a surgeon, we were doing these, but we can actually harvest a piece of your abdominal wall, and that's called an autologous, meaning from your own body sling. We do less of those now because that's a bigger procedure. Most of them are synthetic. And the way this works again, okay, so same thing, you're cutting me like this, looking from the side. So front is over here, back is over here. This is your pubic bone, this is your bladder. This is the vagina right here, your uterus on top of it, and this is the large bowel and the rectum. So what we do is it's a surgical procedure where we make a small incision in the vagina, and we insert the sling. I don't love this slide because it makes it look like what the sling is doing is crimping off the urethra. That's not how it works. The mechanism of what's happening, at least if you have urethral dysfunction, is that, remember I told you we look and see if your urethra tips? So what happens is most women are walking around and you can say your urethra is at this angle. When you laugh, cough, and sneeze, if you have urethral dysfunction, that urethra is going to come down, okay? And if it gets to say right here, you're going to leak. Just mechanically, that's what's going to happen. So what we do is we put the sling in place like here, so it's not constricted. So when you laugh, cough, and sneeze, when it tries to rotate down, it can't rotate down to where you're going to leak, so that's like a hammock. It's an outpatient procedure. If you're real honest with the data, if you look at big series of data, this works very well. It works probably 80 to 85% of the time in well-selected patients. That may sound low, but compared to the things we've had historically, this is a very successful procedure. Those success rates are out past 10, 15 years. So if you have success with this, and that's as far as the data goes, it probably works much longer than that, but we have data out to 15 years showing 80, 85% success rate. It's done as an outpatient. Again, I probably do 30 to 50 of these a year. It's a pretty easy procedure to do. Women tend to tell me that they feel good, not sore within 3 to 5 days after the procedure. We have some minor restrictions for a month after the procedure, but a well-tolerated procedure. So what happens this way? The big finding was the urethral instability. She really, when she coughed, her urethra came down. So she had a well-coordinated pelvic floor within that setting. And so we talked to her about her options, and because of that instability, we went ahead with the sling. Her incontinence resolved. She did well, no complications, and she resumed her active lifestyle. So next slide, different questions. You guys have any questions for first case or for this one? Well, I think it's not so much of a numeric age, it's what's your biologic age. If you're a healthy person and you're our primary care physicians and our anesthesiologists say, you know what, this lady's going to do well with general anesthetic for half an hour, I don't have a problem doing that. If you've got congestive heart failure, diabetes, other things that people tend to pick up at that age, then maybe that's not the wisest thing to do. But you could. And the main reason for it is because it's done in the office. It's like going to the dentist and having a cavity drilled. You don't have to have an anesthetic for it. We do some numbing gel. It's tolerated well, and that's the main advantage over anything else surgically is it's, at least in terms of application of the procedure, it's safer. Now, you trade efficacy. And it helps some. Again, what I tell people is it's flip a coin, 50-50 shot. That I have patients, half of my patients see a noticeable result, the other half, you don't see that. But for a lot of women, we can try and those are yes. So it's not a new procedure, it's not experimental, it's got to get covered. With whatever your constraints is, if you have a 10% copay for a surgical procedure, that's what you're going to pay. But whatever the agreement is, if you're yes, it's going to be paid for. So there are two ways to do. We talk about vectors. There are different ways to do these slings, and the vector is kind of how we tilt the sling when we put it in surgically. And there are certain ways to do it where the vector is a little bit more aggressive, and it does a better job of controlling the incontinence, but there's some trade-offs in terms of the surgery. Maybe there's a 1% higher risk of a complication. So generally we'll start with the less aggressive vector. It's called a transobturator sling. So the sling sits more like this versus this. If patients fail this, so if you're in the 20%, you say, what happens to me? We reevaluate you and make sure we've got the right diagnosis. We might do some urodynamics to see why are you leaking. We'll get to that in the next case. There are other reasons you leak. But if it's still distress incontinence, we'll go to a second sling, and we'll do a more aggressive vector, a pubovaginal sling. And I probably do a couple of those a year, and I've never had a patient that has had problems with reimbursement on that. I have not. All right, let's go to our third and last case. So this is probably, in terms of thinking about things for this format, this is kind of the most complex case in terms of this patient has the most going on. But this is the most common thing I see, that the first two were kind of clear-cut, just diet or distress incontinence. But this is kind of what I see day in and day out in my practice. So this is a 65-year-old female, 3 pregnancies, 3 vaginal deliveries, postmenopausal, multiple years of leakage. Again, minimal leakage with bath, cough, and sneeze. And she tells me, you know what, I have this, it doesn't bother me, I've had it since I was 40, it hasn't gotten any worse, don't worry about it, it's fine. Her main complaints are that she has frequency every 60 to 90 minutes, nocturia, again, getting up at night from sleep 3 to 4 times after she's asleep, urgency meaning she's got to get to the bathroom right now, and if she's not right next to the bathroom, she's leaking 5 pads a day, 3 thick pads, big time bother. I get this line a lot too. She knows where every bathroom I need to read. I honestly hear that once a day. Heads on the swivel. If she was here tonight, she would know that there's a bathroom right on the other side of that down over there. We talked to her, no constipation, not drinking Diet Coke, not all these bad things we talked about in the first case. She doesn't have any of those risk factors. So, what's the diagnosis? So the fancy doctor term for this is mixed stressor urinary incontinence. She has stress incontinence and urgent incontinence. The diagnosis that matters is she has overactive bladder. She doesn't care about the stress incontinence, and she doesn't, neither do I. So, what do we do? History and physical, screening questionnaires. We do our cough test again. We look at the urine, make sure there's no blood. We make sure she's emptying well. There's a rare kind of incontinence that's caused by your bladder not functioning well, and we need to rule that out. It's called neurogenic bladder. It's rare. Sorry, post-void residual. So we have a way, maybe you urinate, you come out, we run an ultrasound over your bladder and make sure you're not full. If you had severe diabetes or an unknown spinal issue, you could have neurogenic bladder where you feel like you're emptying and you've got 2 liters in your bladder. And if you're walking around with 2 liters in your bladder, you're going to leak because you're full. And that's a vastly different treatment than what we're talking about. So we quickly rule that out. A lot of times in these patients, we're going to want to look at your bladder because without those dietary irritants, constipation, I need to make sure that this overactive bladder, this bladder squeezing when it should, isn't caused by a stone or a polyp. And that's something we can do real quickly in the office. It takes a few minutes to do from start to finish. Occasionally, we'll do the urodynamics test. That's the test where we see how the bladder is functioning in terms of pressures and emptying. We do that in the office as well. So, definition, this is kind of wordy, but independent of this, urgent incontinence is your bladder should sit there and hold urine and hold it at a low pressure. And when you want to go to the bathroom, it should squeeze. That's all it should do. But this is, it's holding urine, and on its own, without you volitionally starting urination, it's doing that and it's squeezing. If it squeezes strong enough and you don't have the outlet, the pelvic floor to hold that back, you're going to leak. So that's urgent incontinence. So, is this a big deal? Yes. So, orange is overactive bladder, 35 million people in this country. I think that's low. If you look, well, what else is common? Arthritis, 20 million. So, 15 million more. Asthma, diabetes, very common. Across age, I see kids with this, I see teenagers, 30-somethings, but as you go up in age from left to right here, once you get to the 65 and up, it's 20%. Again, my sense is that's probably more like 30 to 40 if everybody is unanimous. So, observation. So people have this, it doesn't bother them, that's fine. You can do as little or as much as pets. We can do behavioral modifications. So all those things we talked about in the first case, if they're present, with constipation, urinary tract infections, those all within diet, all those things can make this worse or persistent. Physical therapy, which we'll talk about in a second. There's some medications, and then there are a few surgeries we're going to talk about as well. So,
Here I come again. With the urge component to this, all of the stuff I talked about stands. You still have to have a muscle. One of the cool things about the pelvic floor and the bladder is that they function reciprocally. So if the bladder is getting really irritable, the pelvic floor can actually help to counterbalance that bladder. So if you contract the pelvic floor, there's a nerve that goes through the sacrum in the back and to the bladder where they kind of communicate and short circuit from the brain. And if you work on your pelvic floor, it'll actually shut off that bladder kind of irritability there. If you don't have a lot of muscle, you can't do that. Bladder kind of gets to be bossy and does whatever it wants. And then if you turn the wrong way, it fires. It's kind of like being pregnant and getting kicked by the baby, and you have to go to the bathroom like really, really bad. Well, it's not because you actually have to go to the bathroom, it's because you got punched. The same thing if you do sudden movements or you're moving around or you stand up really quick, sometimes that quick stretch creates a bladder contraction, and then you have to go to the bathroom. But not every urge indicates that you have to go. Like Dr. Traver said too, your bladder might not necessarily be full. You just have this little hyperactivity of the bladder. In physical therapy, I put on here the mechanical component to it too. We work a lot in your abdomen when you have urge problems. All of your organs are wrapped in kind of a saran wrap, and they all intermingle and are attached to each other, so they all stay in your abdomen in place. And we find that the bladder sometimes ends up being kind of cinched down, and believe it or not, when you move around, your organs are actually supposed to kind of move in their own little happy dance with you when you move. And if the bladder doesn't have the freedom to move, it can get very irritable, and it can actually be kind of a frozen bladder, and it's not healthy. It's not going to have enough motion. So you move and it doesn't. Another piece of this too is the spinal assessment. A lot of people have, you hear of people being off, or their alignment is off, or they're having back problems that, I'm having a word problem, my chemo brain today. The bones that attach to each other may not be lined up well. And when that happens, if you look at the front here, the bladder sits right behind this big bone right here. And if these bones are off a little bit or shifted, so what that would look like, I can hold this and do it. If I've got my pelvis, it can roll like that a little bit, or like that, or like that, or like that. So the whole pelvis moves, and that's that sloppy pelvis I talked about. When that happens, the bladder's right underneath there, and we find that often will also create a lot of bladder urgency. When things are lined well, the bladder calms down, it's not getting stretched funny, and it's not getting compressed. So that's one thing that we would want to rule out if you end up at physical therapy. If you end up with us, you've already had those bladder tests with Dr. Traver's office, saying that you don't have those, polyps and stones and bad things that we can't take care of. So it just takes those same pictures and builds off of that. Electrical stimulation we actually use too, and it's a great thing to start with sometimes. I know they do it in their office as well, and they're going to be talking about a component of this. Electrical stimulation can calm the bladder contraction as well. So we can put it on a setting that inhibits urge and just kind of down trains the bladder and says that it can't be bossy anymore, kind of puts it in its place. And so you do a number of things. We look mechanically, we look at your strength, we look at that force coupling, that cutting, and electrical stimulation as a component there too. There's also a question about the fecal incontinence too. And when we had looked at that slide, this might be a good way to see it. The pelvic floor does not discriminate against which opening. Women have 3 openings. If you're having bladder problems, it is actually really common to also have bowel problems. The same muscle, the same nervous system. If something gets overstimulated, the bowels are going to react the very same way. And so if you can't close the urethra, you're likely not to be able to close the rectal opening as well. And that's quite embarrassing. These kinds of treatments apply both for bladder dysfunction and bowel dysfunction. And the muscles around the bowel, it's kind of like a vestibule when you enter in a double door system. You've got your outer door, and there's also an inner door. And the inner door is kind of a reflex. When stool comes down and stores in the bowel, that inner door is going to shut off and say, I'm out. I gotta go to the bathroom. And you guys have an urge. If that outer door is not ready, and that's that voluntary door to control, if that outer door is not ready to hold, you will have a bowel movement because that inner door is shut off and said it's time to go. So having a really good amount of strength and control there can help to control fecal incontinence just as effectively as it can help to control bladder incontinence as well. The stool that comes down the bowel is supposed to be heavy. You know, it comes down here and it stretches the wall of the bowel. When it reaches a certain amount, that's what tells you have to go to the bathroom. We also work with different devices like a balloon, things like that. Sometimes the bowel gets really reactive where it thinks it has to go to the bathroom with barely anything in there. And so we would work with you to build your tolerance to storage. That bowel wall there is supposed to store. So we build your strength, improve your storage, and then you're not walking down the grocery store thinking, oh my gosh, I have to leave my cart because I have to go do this thing. So that applies just the same as with the bladder dysfunction.
If you get through those gates or they're not applicable to you or we need to clean things up a little bit more, we have medical treatment. So this is where you come back to me and I talk to you about prescribing medicines. There's two classes of medicines. First is anticholinergics, second is beta agonists. There are a ton of medicines in this class. I just gave you a few. There's only one in this class. So the way these work is we think this is an option for you. You're motivated to try different things to help with this and take a medicine. These medicines generally take 1 pill a day, and they can be effective in controlling this overactive bladder. The way they work is nerves talk to each other in the bladder wall, and they essentially short out that signal that's causing the abnormal contraction. The problem with them, though, is they don't work in everybody. If I'm real honest with patients and say, what are the odds that I'm going to give you this medicine today, and a year from now, you're going to be still taking that same medicine, you're going to be happy with it because it's still working, and it's not costing you side effects, and it's not costing you an arm and a leg in terms of it's pretty low. I'd say it's less than 50%, what you say. Some of the medicines are better than others, but those are just numbers. I have patients that are very happy on these, but they don't work across the board. The beta agonists are newer. They've been on the market for maybe over a year. And the one drug is called Mirbetrix or Mirbegan. It works in the same fashion, but on a different receptor. Because the receptor is different, the side effects with this that we worry about are dry mouth, constipation, which we covered in depth, that that's bad, drying of the tissues, can't be on it if you have glaucoma. This medicine doesn't have any of the side effects. It can cause rarely some increase in blood pressure, very rarely. I have a number of patients on this. I've never seen it in my practice, so I've never had a colleague that's seen it either, but we monitor your blood pressure a little bit more closely. My sense is this medicine tends to work a little bit better than these. The problem is it's expensive. New medicines that are new from pharma to the market cost a lot more. And that's the problem. I have a lot of patients that have done very well. We give samples, we give you a month, you try it, changes their life, they're happy, and then we say, okay, we'll send you a prescription, and they call me back an hour later and say the pharmacy wants $238 a month for this. And that's a problem because that's a lot of money for everybody. For anybody. So that's the main problem with this medicine. It's not perfect. Again, probably 50% of patients are on this if they can afford it or if they have a good drug plan, less side effects, but the cost is an issue. So if we get by the medications, they're not working, they're causing side effects, or they're too expensive, what surgical options do we have? We have Botox. And when I mention Botox, when I think about Botox, this is what I think about. Probably most patients. Unfortunately, I don't get to do this. This looks more fun than kissing Botox. But this is what most people think of Botox. Botox is a neurotoxin, and what it does is, again, it short circuits out the nerve transmissions between nerves. we use it in the face because you get wrinkles because you're squinting or you're smiling. What it does is it paralyzes that muscle that dermatologist is injecting that into. So you can't have those crow's feet because you can't raise up your cheek. The neurologists use it for headaches. We use it for overactive bladder. Orthopedic surgeons use it for kids with spastic muscles because of cerebral palsy and other diseases like that. So it's commonly used across specialties. The way we use it, again, is in the office or in the operating room. We put a scope in your bladder, and I inject the medicine throughout your bladder into the bladder wall. And it delivers that drug into the bladder wall and shorts out that signal that's causing the bladder overactivity. Like the bladder, or the urethral bulging, it's well tolerated. I can do it without an anesthetic. It doesn't take, I did one today, it probably took me 5 or 6 minutes to do the complete treatment, not part of it. Issues with it, it's not perfect, like all these things. I would say it works very well where people are quite happy with it 60 to 70% of the time. So it's not horrible, but it's not a sure deal. The main problem with it I see, and if it works well, people don't have a huge problem with it, but is it wears off over time. Okay? So if the rep from the company was here tonight, she would tell you that it can last 8 months. My experience is the patients that I have on it chronically, they can go 3 to 6 months. And so twice a year, you're going to come in and we're going to do this application. And for a lot of people, that's not a big deal, but for some people it is. And so if you worry about that going forward, that might be an issue. The other treatment we have, and I've got a left brain and a right brain kind of picture, depending on how you think about this, is InterStim. And so Aaron mentioned it before, and I always struggle kind of explaining this to people, and I might hijack how you said the bladder's being bossy. There is a nerve that runs from many nerves that run from your bladder to your brain, but there's a specific nerve that we know about that sends an afferent signal. What that means is from the organ to the brain, that it's irritated, it's turned on, and it gives your brain a signal that, hey, I've got to go to the bathroom, even when I don't. And then, so that gives you the sensation that you have to avoid. The bladder, or the brain fires back and says, okay, well, time to go, and the bladder squeezes and leaves. So, we know where that nerve is. If you look at this model, okay, this is my pelvis, this is the front side, this is the back side. This little bone in the back is called the sacrum. It's like a piece of pizza, it's a triangle. It's got 4 little holes on either side, which are called foramen. It's the fancy doctor word for hole. And right next to the third one down, so the S3 foramen, there's that nerve is right there. So I know how to put a needle in that hole and put a little wire right next to that nerve. And then we run that wire to this computer. Okay, this is all inside your body, nothing's on the outside. And it's a computer and a battery. What that essentially does is it shorts out that aberrant signal. It gets rid of that signal that shouldn't be there, and it gets rid of those symptoms. Okay, so what that looks like with real anatomy is, again, looking at patient's backside, there's the foramen. Wire goes through there. We run it under the skin. And I put the computer battery kind of right here. And there's a remote control that kind of looks like this. You can control it just like you flip channels on your TV and run different programs and turn it up and down. And it sounds like a crazy thing, but it's fantastic. So this is what it looks like. You have it placed, and we do this in the operating room under some sedation. We numb up this area. This is what the wire looks like, the end of it that's next to the nerve. It goes through that foramen, and then it routes through a short wire. This is the computer battery. This is a pen just to show you scale. And that hooks up, and that's the treatment. To have this, this device is obviously very complex. So there's some expense with that, which is fine. The insurance pays for this. But this doesn't work in everybody. In well-selected patients, and I do probably, I don't know, I feel like I do maybe 30 to 40 of these on a good year. But in well-selected patients, this is going to work in 70 to 80% of patients, and I'm very happy with it. But because it's not 100%, your insurance company is not going to let me just put this in you, because 1 out of 5 times if we've put an expensive computer in your body that doesn't work. So the workflow is that if you're interested in this, we put a temporary model of this. So we put a, not under anesthesia, we numb you up, and we put a temporary lead in that same spot, and it goes to a wire on the outside to a thing that looks just like this, and you wear it on your hip for a few days. And if it works, your symptoms are going to be better rapidly in those 3 days. And you tell us, yeah, it's working. And we take the temporary wire out, give back the little beeper box. And so this patient, in my mind, this patient's a little bit better suited for InterStim, and that's what we did. She did very well in the test. She got a full implantation. She now, again, she was urinating every hour and a half, can hold it 3 to 4 hours. No urgency. Other than the rare stress incontinence, which wasn't bothersome, and still isn't bothersome, no incontinence, she's not wearing pads anymore, down from 5 a day. And now instead of getting up 3 or 4 times, she's getting up once. So the question was, are there psychological components to frequency? And that's a good question. And the short answer is yes. So you can train your mind that you feel like you have to go. It doesn't have anything to do with anything bad going on in your pelvic floor or your bladder. It's psychological. If we get the, it's kind of a subtle diagnosis, but you see it more commonly in kids and younger adults. But you can do behavior modification. It's the simplest thing in the world. I give patients a pen and a piece of paper, and on day 1 in the stopwatch, and on day 1, say you're going every 5 minutes, you hold it, and you're not going to go at 5 minutes. You're going to wait until 6 minutes, and you're going to see the world's not going to end, and you're probably not going to leave. And you do that for a day, and then you go 7 minutes. And over the course of 6 to 8 weeks, you get out to where you want to be, 2 hours, 3 hours. And if you're motivated and you've got the right diagnosis, and you don't have this other stuff that we're talking about, the success rates with just that program, as easy as I described it, are as high as the medication. Now, you've got an issue where something else is going on, you're constipated, sloppy pelvis, the nerve, that's not going to fix things. But yeah, if that's your diagnosis, it's as simple as that to fix it. Yes, ma'am.
I've heard of the Kegel method. Is
Yes,
that no longer valid or used?
Okay, so a question for Aaron is, are Kegels, are those valuable or out of date?
Yeah. Poor Dr. Kegel he invented Biofeedback, and then all of the exercises got named after him, and I don't think that was his intention. So the pelvic floor contractions that we're talking about is a Kegel contraction. And so yes, they're very valuable. You must do them. You must know where that is, and that's what holds the whole pelvis together. It's just, you can call it Kegels, you can call it pelvic floor contractions, you can call it whatever you want, you just gotta have it.
Before we take your question, what is your thought on, I'll talk to patients a lot about, well, I think you should do physical therapy, and before that sentence is out of my mouth, it's, I know how to do Kegels, doctor. So what's your sense of when people are doing this correctly, what frequency that are people doing Kegels incorrectly?
I would say again, yeah, the failure rate on that is also bad because most people don't even know where it is. Also, doing the contraction to an intensity where it would actually fatigue the muscle. You can sit there and you're watching TV or you're driving a car or you're chewing gum. You're probably not doing it right. You have to actually create fatigue in a muscle for a muscle to get stronger. And if you can barely find this muscle, you have to stop and you have to think about it. And not to mention, you have to get a contraction so you're getting that first layer, you're getting the second layer, and you're getting the third layer without actually getting all the other muscles involved too, so you can truly isolate it. So there better be no TV or car driving unless you want to get in an accident or other things going on. You have to lay down and actually think about it. And then we want you sitting up and thinking about it. And then we want you standing because that's where all the problems come from. This is a muscle that has to be able to resist gravity and standing. And if you can't find it laying down, you're surely going to have problems when you're trying to stand. So there's quite a science behind it. Repetitions depend on the person. Some people can do 5. Some people can do 20. Some people can hold it for 2 seconds. Some people can hold it for 10. So that's where the physical assessment that we all do is so crucial because it has to be very customized for the person.
So the question is, if you have your uterus removed, a hysterectomy, do those anatomic changes cause some of it? And so I can address part of that in here probably next week. So when you have not a gynecologist, but we do have to take out uteruses when we remove bladders for cancer. And like Aaron said, the organs are all attached to each other, so there's some ligaments here called the cardinal ligaments that need to be taken down to remove it. And so the biggest thing that causes, honestly, is support to your vagina. The apex, or the top, the roof of the vagina, isn't supported anymore. So the big thing that we can see with that is something called pelvic organ prolapse, where the vagina will actually sag down and in some cases can bulge out of the opening of the vagina. In terms of the bladder support, the main support, as Aaron was talking about, is on the front side, the obliterated umbilical ligaments that are up here. There is a ligament here that's taken down. I don't have a sense of that. I don't think that's going to predispose as much to overactive bladder. But certainly we see issues with prolapse of the bladder prolapsing out of the vagina. If that happens, that can cause a lot of these symptoms because the bladder is kind of backed over itself and it can't efficiently empty because of some of the angles that are created. What would you?
I would agree too. The uterus is really a big protective mechanism too because the uterus lays over the bladder and is kind of like the big brother who protects it from all of the intestines above. And the uterus has a lot of really big ligaments that attach into the sides of the pelvis and create that anchor. So it really looks like this, don't touch my bladder. So when you have to take out the uterus, the intestines fill that space. And so guess what? Management is so important after you have a hysterectomy. You better make sure you're going to the bathroom. The more full and the more heavy your bowels are, the more likely you are to put strain on top of the bladder. And because that bladder is going to probably have a little more mobility because that bladder attaches to the front wall of the uterus, it's more likely, like Dr. Traver said, for it to kind of fall into that vaginal canal and prolapse. And so if you've had a hysterectomy, your pelvic stability is crucial. Bowel management and pelvic stability. And when I say pelvic stability, I mean abdominals, pelvic floor, and hip muscles, so that you have that nice anchor to hold and to hold that vaginal canal up because the muscle encloses the vaginal canal.
Yep, so the question was, there's some new options available from the pharmacy that you don't need a prescription for, and the main one is called Oxytrol, it's a patch. And absolutely, it's the same, it's in the same class, they work the same way. The delivery mechanism is different, you're putting it on as a patch instead of ingesting it. I think they work well. The nice things you can do with the patch, excuse me, push dosages a little bit higher in terms of the main side effects from the patches are irritation of the skin and rash. And so you have to be real careful to have a really good cream application regimen. And there are 4 or 5 sites you need to rotate every day. Independent of that, though, you can push the dosages. So a lot of times what I'll do is if somebody's on this and they say, hey, you know what, I'm 80% better, but I want to get a little bit greedy and get to 90, 95. And so what we'll do is sometimes we'll try to push the dose on one of these medications. And then they come back in 3 weeks and say, hey, I'm a little bit better, but I'm constipated now, not good. So what we can do is back down that dose and then try an Oxytrol kind of patch because they're other than the skin, there's less of the dry mouth constipation side effects. So, but they're not a lower dose. They were probably one of the first medicines in this class. When they were full-on prescriptions, probably I didn't write as many scripts as for these. People tend to not. I think people prefer the simplicity of a pill you take every day versus having a skin regimen. But for some people, it's a good option. What do we recommend for a prolapse bladder? Depends. So if you just have a prolapse, and I see this twice a week where somebody comes in and they say, I got sent to you today because my GP said I have a prolapse bladder and you need to do something. I said, okay, well, let's evaluate and take a look. And yeah, it's a little prolapse. And you say, well, what symptoms are you having? And they say, none. I didn't even know they had it. I had it until they told me. We don't do anything. If you're not symptomatic, we leave it alone. With the bladder, which we see, you could have pain. You could have, if that tissue is constantly hanging down, you could have desiccation or drying of that tissue, which can cause irritation or bleeding and pain. If that their bladder and into their kidneys. So certainly if you're having those symptoms, we need to do something. But if you're not having any symptoms, if you're just having a grade 1 cystocele or rectocele, which is real mild, a lot of times we won't do anything. Patients say, well, is it going to get worse? Maybe, probably not going to get better, but it might stay the same, it might get worse. If patients are symptomatic, then what do? Then you got a couple options. First option, simplest option, is a pessary. Okay? So what a pessary is, and these ladies are the experts on pessaries, but it's a piece of plastic that we fit to your vagina that will hold everything up in your vagina. And everybody has different shape, different size vagina. So if you can get a proper fit, women will tell us that they don't even know they have this, that it holds everything up and it's going to fix those symptoms. Sometimes we can't get that fit and it's uncomfortable for women or they're intimidated by having to use this. And then we have to go to surgical options. There are surgical options to fix it. And you ever meet a surgeon that tells you, don't do surgery, you want to run from that surgery. So we only do surgery if patients are really symptomatic. It's bigger surgery to fix in terms of recovery, in terms of risk. The problem is, even in the best of hands, okay, you find the best guy in the country or whatever they think is the best guy in the country, the failure rate is about a third. So you're talking about a semi-elective procedure if you're just doing it because you have it, where there's some risk and there's some recovery time, and the failure rate's a third. So if you're having those symptoms, there are surgeries to be done. There's also another surgery called a colpopexy, which is more of an internal surgery, but those are the options. What else do you guys have to say about pessary? If you come to see me for a pessary, I say we can do that, and then you get referred over to our team.
Well, it's kind of like a round disc, you see it, it's like a silicone disc, and you fold it in half, and you just place it up in the vagina, and you just push it in. Can't go to your brain or anything like that, it just stays right in the vagina, okay? The key is that when you're hoping that you're able to make sure you're able to empty, your urine easy, that you should not even feel it. And then we tell people you can take it out daily if you want to take it out at night and just let your vagina relax, or if you want to take it out once a week. There's some people who have really bad arthritis, they come in once a month and we have to take it out, we clean it, wash it with soap and water, pop it back in. It's no biggie. What you do is we first size you, okay, find out what that little disc, what one fits you the best, and we have to stand up, we have to bear down, we even kind of have you jump up and down a little bit, see if that pops out. What we notice most is if somebody's having a hard bowel movement and it plops out in the toilet, and they're like, oh, what do I do now? So then I always tell people, we always send them home with a pair of gloves. They just take it out, wash with soap and water, pop it in a bag, and bring it back, and we can maybe go up another size. So these are the things that we do. We just don't let you just go out the door. We work with you. You see Lisa and I a lot when you're in our office. We're on your corner, and we're on your team because we're trying to help you get through it. It's a process. So you're not alone, and just remember we can do different things to help you.
So the question was, if you're born prematurely and everything's smaller, I think the question is are you going to have problems later in life with bladder function? Is that a fair question? Yeah. The problems that the congenital, meaning born with problems that people have with kidney function, doesn't really have to do with size. It has to do with the development when you're in your mother's womb. And there are lots of things that can happen with how the kidneys drain. The ureters are the tubes that drain your kidneys to your bladder. And you can have, they're just supposed to plug in, like plugging in a hose into the side of the wall. And sometimes if that is malformed, that can be a problem. There are hundreds of different congenital problems that it just has to do with formation of the organ that can cause problems. So it's not so much of a small versus big. It's more how organs were formed if they were set up properly. A little bit. So what I always tell people is there are two kinds of kidney doctors, and I'm the dumb kidney doctor. So if you have kidney cancer, okay, and you need your kidney removed, or you have kidney stones, or your ureter is malformed and you need your ureter rebuilt, then urologists, we're the guys that deal with that. We're the kidney surgeons. We remove kidneys and we repair them surgically. If your kidneys don't work well, okay, if you have diabetes, if you have high blood pressure, if you aligned structurally, they just don't work properly. Then the doctors, then you see the smart kidney doctors, those are the nephrologists. Those guys, their hands don't work so well. You know, we make fun of ourselves for being dumb surgeons. They can't move their hands around, so they're not operating on kidneys. They're thinking about them in managing your kidney dysfunction with medication. So what you're probably referring to is chronic kidney disease. And there are different stages, stage 1, 2, 3, and 4. It basically is, I'm not expert at it, but it's a way to stratify how well your kidneys are working relative to normal. And as you get farther from 1 to 2 to 3, you're getting closer to needing dialysis. And it's basically a function of what percentage of your kidney function is in place. But if you have that, a nephrologist would be the doctor to manage that, not a urologist. Right. So you have little nocturia, little constipation. You know, your primary doctor could start. A lot of people see their gynecologist for this. You're talking to a urologist right now, so I'm a little biased. I think we maybe do a little bit better, but if we had them in the room, they might tell you the other side of the coin. But there's a little bit of overlap. Those are the three specialties that certainly if you had a severe problem with constipation, things we're working on that we're not getting you where you need to be, then we'll send you to a gastroenterologist who is a bowel doctor. But generally to start either your primary or gynecologist or you know, we would be happy to see a urologist. Okay, so that's a good reminder. I forgot to mention Aaron was talking about that nerve, that interstim procedure that I talked about. That same nerve that we target and isolate with our little wire and short it out with the computer, that is the same nerve where people are having fecal incontinence. That procedure will fix that as well a high percentage of the time. Now, if you were coming to me with just pure fecal incontinence, I'd probably tell you, you know what, you should work for your primary and make sure you're not constipated. There's some gastroenterologists in the area or general surgeons that do that, and I can give you some names afterwards. If you've got the urinary symptoms with it, and we're more focused in theory on the urinary symptoms, when you get to a technology like that, or we send you to physical therapy, it's two birds with one stone thing. But if you just have the fecal incontinence, probably urologist is not the guy to start with, just because there's some other things they need to rule out. They need to rule out polyps as well, and other things going on that they're going to be able to do with their procedures. So when you go to sleep at night, you have to urinate. So that's kind of the thing. The first thing I ask people with that is it high volume or low volume? Okay, so it's high volume. So the next thing we do is we do a voiding diary, which means we give you a sheet of paper with a pen. We have you go away and you mark a few days and come back and bring it to us. And basically what you mark down is when you urinate, how much you urinated, 2 ounces at 2 o'clock, and then what you're drinking. And you look at it, and there's a ratio. I'm not going to tell you the ratio because then people cheat, but you show over a certain amount of urination, urine production at night is abnormal. So if it's under that number, if it's lower, if you're getting up a lot at night, and it's low volume like we had in our example, that speaks to a storage issue, a bladder issue, or a prostate issue if we're talking about gentlemen. If it's over that percentage, you can still have a little bladder involvement, but then you're talking about a urine production problem. It's not that the bladder is so horrible, it's that you're making too much urine at night. And so the common things that can do that are heart and lung problems, and the most common thing is probably sleep apnea and reabsorption of fluid. I don't know if you noticed on your legs at night, if you look, you've got a sock line, and then you take the socks off and go to bed, and when you wake up in the morning, that edema there is gone. So what happens is when you lie down, that fluid is reabsorbed by your bloodstream. And your heart is really good. It says, whoa, there's a little bit more stretch here. There's too much fluid on board. And what it does is it sends a signal to your kidney, chemical signal that says, hey, kidney, we got too much fluid here. We need to make some more urine and get this fluid out of here. And then your urine, you make a ton of urine, and no matter how big your bladder is, you're going to have to go at night. And so we get you in with your primary care, and they look at your heart and lungs and make sure you're doing okay. We talked about sleep, and maybe we get you a sleep apnea study. If none of those things turn up, and if one of those things turns up, they treat it. But if we don't find any of those, which is common, what we recommend is, number one, you lay with your legs above your heart for an hour in the afternoon, okay, because that'll start that fluid reabsorption, and when that's going on at 8 o'clock at night instead of 3 o'clock in the morning. We medication that we can use that basically blocks that chemical signal.
For the protection of your account.
Those are the big things we do for that. So the key is the ratio in knowing what that number is and what that percent is. Because people generally, you seem to have a pretty good sense of it, but I found that people don't have a very good sense of how much urine they're making at night. So that's the most important part of the boys' diet. What else? Anything else? All right, well, thank you for coming in. We appreciate it. Drive safe, okay?